All right, let's get going. So welcome everybody. This is the APDA, American Parkinson's Disease Association, Central Pennsylvania Information Referral Center COVID update. This is our third update. We've done two of them, which are available online as well as on YouTube and in our website. And we have covered a lot of topics before, but today we are delighted to have two very senior experienced movement disorder specialists, Parkinson's doctors, who are from two ends of the country. We have Dr. Cheryl Waters, who is a professor and a senior movement disorder specialist who is in New York City, and where we have the epicenter for the COVID pandemic and lots of patients there. And she has oodles of experience working with Parkinson's disease for well over 30 years. And I've known Cheryl for a good part of that time period, and it's just wonderful to have you here. Welcome, Cheryl. Thank you for joining us.
Thank you for inviting me.
Okay, great. And then what we have, the other person who's here with us is also a great friend of mine, Pinky Agarwal. She is also a professor of neurology and movement disorder specialist. She's in Seattle, Washington. And this is another area where the COVID pandemic has had its mark, and a lot of people there have been sick. Although we hear that things are getting better in Washington State, and you've been very good at the social distancing, and the numbers are coming down. So that's very good news. So we have covered a lot of this topic before, but I like to hear, and I've expressed, what I thought was the consensus opinion in the previous two programs. But here we have two experts, so I like to hear each of you talk, each of the talking points that we've talked about before for our audience, so that everybody can kind of hear what's going on in the rest of the world as well, rest of America as well. So the first question to each of you, and I'll ask Cheryl to answer first and then Pinky. The first question is, does Parkinson's disease pose an increased risk for COVID? And my answer has been no. Just because you have Parkinson's doesn't mean that you're going to get COVID-19 infection. Has that changed, or is it still the experience?
No, I agree with you that this does not increase the risk for COVID, having Parkinson's at all.
Okay. Pinky, you agree?
Yes, I would agree. It's just that a lot of the patients with Parkinson's are in that older age group of more than 60, and sometimes comorbid conditions which make them more prone. And I did lose one patient, one of my PD patients, to COVID, but she had she had a prior history of cancer. So I think probably that's what made her more prone.
Okay, so that's a good segue into the second question, which is age is an issue, which we all know that the older the patient, the higher the risk. And of course, Parkinson's is an age-related neurodegenerative disorder. So many of our patients, well over 80% of our patients, are over the age of 60 or 65 in many cases. So the comorbidity is higher when you're older, but if you're a healthy person and you're being very good about keeping up with your health, then do you really need to fear COVID just because you're older? It appears that from what I'm reading in the literature and what's in the news media and what's published literature, it seems like just being old is not enough, but you have to also have comorbid illnesses. The more illnesses that you have, diabetes, hypertension, cancer survivor, so on and so forth, then you are at a higher risk. Is that a general sense that you all get as well?
So I agree with you, everything you're saying. I think that the comorbidity, the frailty, we'll talk about that. I know that we've talked about frailty before. I'm a big one in encouraging my patients when they first come in to make sure they don't lose weight. I don't want people to lose weight at the beginning of the disease because I don't want to become frail later on. So I think if you go into the disease, if you're in the disease and you're exercising and you're coping well, this should not raise your risk for COVID.
Gotcha. Is that, Pinky, you have any thoughts on that?
Yeah, so definitely older with comorbidities increases people's risk, but also we've seen health professionals who are working in, getting exposed to probably a larger viral load, and who we've known have been otherwise healthy, who've become quite sick from this virus. So probably it's for more frail, even a small viral exposure could make them sick. If someone's healthy and you get enough of a viral load, probably it could be making sick. That's where the social distancing is important, that at least you decrease the amount of virus you're getting.
Excellent. So I think that's a great point, and I'm glad that both of you emphasizing that. So staying healthy, doing exercises whenever you can. Again, we'll talk about how to do exercise when you are isolated. A, and B, nutrition and keeping yourself healthy and doing all the right things, taking medicines on time, being compliant, and not skimping on any of your routines, even during these hard times, is an important thing. And also, as Pinky was saying, reducing the viral load. So basically, if you are in a situation where there are a lot of people with the virus that are surrounding you, then you are at a higher risk. So for example, going to the grocery store at times when there are very few people, or if your grocery chain is allowing for elderly people certain hours, they go at a certain time, and many grocery chains have done that, they said, okay, morning from 8 to 10 is your time or whatever, then that would be best time to go and do your grocery shopping. So those are kind of important things to keep in mind and follow through on it. So, which again, now brings up the next question, which is, how will my symptoms, meaning Parkinsonian symptoms, behave if I get sick with COVID? Again, my answer, stock answer, again, limited experience here. We don't have a lot of patients with COVID. And we have, luckily, and we'll keep our fingers crossed, so far I have no patient of mine that has gotten COVID with Parkinson's disease or even extended movement disorders. There's nobody. The stock answer has been that as with any other infection, if you get infected, whether it's respiratory infection or urinary tract infection, yes, your Parkinson's symptoms are going to get worse. You're going to have a bit more tremor. You're going to have likely more have dyskinesia. So, Pinky, I know you already lost one of your patients to this disease. So, and again, I don't know whether Cheryl has had some experience with this as well, but I'd like to hear when this disease came on to this patient, how did it affect their symptoms?
So she was living in an assisted living facility, and then one or two of the people there were diagnosed. And then my patient had this pre-existing history of cancer. And then so she came into the ER basically with high fever. Now she's been to the ER in the past with UTIs and other things. But this time when she came in, she was almost delirious. And when they did a chest x-ray, they saw the bilateral, opacities that you showed, that we've talked about, that's typical of the disease. And because of her pre-existing illness, and by the time she came, she was quite delirious. So it was hard. She could have done with a ventilator, but then she had signed DNR before. Her power of attorney, her brother was there, and he decided, in view of the comorbidities and the patient's, express wishes before, they decided not to go with the ventilator. And so in about 24 hours, the oxygen saturation went down.
Okay. So just to summarize for the audience here, some of the words, just to make sure that all of you follow along, DNR means do not resuscitate. It's a wish that many patients in the elderly state, they might say, hey, if something bad happens to me, I don't want to be intubated, I don't want to be ventilated, etc. I know many of the listeners here might have done this already, but for those who don't know that term, DNR means do not resuscitate. And it can be in different forms. And there's one form in which you can say that I don't want to be intubated no matter what. So this patient of yours, Pinky, had that wish. So the doctors followed that wish, right? I mean, that's what you're saying, right? Yeah. And eventually she passed. Cheryl, your experience, have you had any patients? Yeah.
Yeah, so my experience, the patients, we're doing patient phone calls, we're doing virtual medicine. So when I hear that somebody's sick or I'm returning a call from somebody, they tend to have flu-like symptoms, the fever, the weakness, malaise. They tried to isolate themselves. And the challenge, of course, is if you have the diarrhea, then you could become very weak, right? And your medicines, in fact, might be too strong for you in that instance. And when you feel weak, you feel very weak. But I'm amazed at the resilience of patients that I hear, 75, 85 years of age with Parkinson's and COVID, and they survive. The ones that I think I'm not going to hear from again survive. So I just think people have resilience and somehow they can get through this. You feel awful for the time being, but I can't tell you of any of my patients I know that are actually in an ICU right now.
Fantastic. Lovely. Have you lost anybody in the pandemic so far? Has there been any mortality that you know of your own patients?
I don't think so. There's one that I'll tell you, there's one where I had the conversation with the daughter that you better have the conversation about not going to the hospital, not getting intubated, because I felt he's very advanced. He has difficulty with cognition, his thinking function. And I just got a request for a renewal of his medications yesterday. So lo and behold, this man in his late 80s, maybe 90s is still around. And,
I guess we should pat ourselves in the back that we take good care of our patients.
I know of another patient, not Parkinson's, but there's a patient who has been getting dialysis, which has been getting dialysis continuously. And even on a regular basis, the doctor tells me that this patient about once a month ends up in the ER with something or the other.
Right.
But she got COVID. They dialyzed her in isolation successfully. And she recovered. She didn't have even her usual, monthly illness, and she's well and
unbelievable.
That's great. That's great news. That's wonderful to hear from both of you all who have seen a lot of these COVID cases. I think this puts our listeners' mind to rest that if we do all the right things and follow the doctor's orders and continue social distancing, I think the results are very good, and that's very, very encouraging. The next topic, which is a nice segue to say, how do I keep myself healthy, right? So exercise, which we know is an important part of well-being in Parkinson's disease. And many of them used to go for gym classes. Many of them went to dancing classes. As you know, the rage is now rocksteady boxing. A lot of people participate in that and so on and so forth. But many of those things have now closed down. Now we here in Hershey, we are having online classes for exercise, and we're provided a video, and we do have online tutorials for how to do exercise. But any thoughts and any suggestions on what you have worked out with your patients in terms of what they can do at home in terms of home exercises? Do you any tips?
So I think the hardest cases are those patients who are in those big buildings in New York City and they're not allowed to leave their apartments. So that you may or may not have that experience. So I have a lot of patients who've gone to Long Island and some of their suburban places. They have lots of land. They can walk around the block. But when you're in a New York City apartment and your doctor orders you to stay inside,
right,
that becomes a huge challenge. So they do the best they can with the YouTube videos and the classes online and just walking around the apartment. But everybody seems very determined to do their exercise. I would suggest you put on music and dance, because just dance on your own, listen to good music that you like and just dance, because that's a very good physical activity.
Yeah, I agree. I think the literature would also support that, right? I mean, one of the most compelling pieces of exercise therapy is what David Leventhal and others have done in New York with the dance exercise therapy program that they have done. And I would plug in here that David Leventhal does offer free classes during this pandemic. So anyone who is interested could just go for a Dance for PD, which is their website, and go there and download the links to do the exercise. Pinky, your thoughts on exercise, anything that you have learned that has helped your patients?
So in the Seattle area, we already had a couple of physical therapy specializing in PD groups that were doing virtual online classes, meaning the people could see the physical therapist and the physical therapist could see the patients. So it was sort of more interactive. So some of those are still operating. There's a local company that started even some breathing exercises just to make sure people, and this is again, they're posting online free these classes that are for exercise, that are more interactive, but they keep changing it around so it's not monotonous, the same. So either just watching videos and doing it, or doing one of these interactive classes where they can actually see the therapist and the therapist can see them.
That's cool. That's great. That's great. Thank you for all those suggestions. One other thing that I have recently come across, I have one client who had an old Wii game, that WII game set, and he called me up and he said, "Can I play that game?" I said, "Yeah, go for it." So, and he's been very happy, doing that. He's been standing on the platform, doing the exercises. I did caution him that if he hasn't stood on the platform for a while, he should at least rehearse it before he gets going. But last time I heard, he's still doing it and he's enjoying it. He's playing golf on his TV and so on and so forth. So and those of you who still have the V, and I know it was a rage about 5-10 years ago, this is maybe a good time to dust it off and just use it if you want to use it.
And also, at least in the Seattle area, a few insurance companies are allowing virtual physical therapy.
Mm-hmm.
Oh, wow.
And they're
Yes,
actually
we're offering it too. Yes.
Okay.
But I want to just say one point. When I call my patients for their virtual visits, I get a chance to look at the environment and see how safe it is. And I want you to be very careful, everyone who's listening. Do not fall, because I don't want you in an emergency room right now.
Right.
You don't want to be in an emergency room right now. So make sure that your home is not cluttered, it is safe, because we really don't want you to fall.
Right. That's a great point. Thank you for bringing up those very, very important points. So let's move to medications. So based on the general knowledge and common sense ideas, the only cold medicine that I have brought out as a concern would be dextromethorphan and this drug interaction with monoamino oxidase inhibitors such as selagelene, rasagiline, and safinamide. And again, it's a theoretical risk, and we haven't seen a lot of it. We haven't seen serotonin syndrome, or we haven't seen hypertension, or for that matter, any other kind of side effects when using dextromethorphan. Although theoretically that is a concern, and this is an issue that we all worry about. Now, again, in practice, in real life, you've had patients with this disease. They have taken cold medicines. They have taken whatever, NyQuil, Robitussin, whatever, with DM or no DM. Have you had any issues with these drugs and any issues with any of the other common drugs that we use for cold and fever management, Tylenol, Motrin?
Yeah, I don't think people are taking much more than Tylenol. I don't hear of people taking anything else. And I don't feel as strongly as you about the dextromethorphan. I just give my patients free rein to take whatever they tolerate. But honestly, with the COVID, I haven't heard people doing more than liquids, Tylenol, and not much else. And their doctors are constantly prescribing Z-Paks. It's not me. The doctors prescribe it. Yeah.
All right. So in my view, again, I'm also very liberal about dextromethorphan. I don't have strong feelings at all. In fact, I tell them to take it. There's no problem. I have never seen it. A drug interaction I haven't seen in the last 30 plus years. So I have no issues with taking Robitussin. But having said that, cough is a major symptom.
Right.
And if you have a cough suppressant that you need to take, is it okay to take Robitussin DM or Robitussin or whatever, NyQuil, whatever company? Is that okay or not?
I think so, but I'm not the one prescribing it. Pinky, who prescribes for your patients?
The cough, well, the over-the-counter really, I think at this time, if the cough's bad, they need to take what they need to take. So if they're calling and they are on rasagiline or selagelene, but they need something in particular to suppress that cough, we're just saying go ahead with it, because even before this, I don't think it was a big concern.
Right.
The side effects. As far as the fever, there was some online reports from some countries, I think especially France, about maybe avoiding Motrin. And then there were some that said there aren't enough studies, but I don't think there are enough studies on COVID for anything. So we've been telling preferable to take Tylenol rather than Motrin.
Right. Okay, great. So I think we covered that. We've covered the same topic in our previous sessions as well. We specifically brought these 2 points again. And then going on to talking about missed appointments and cognitive impairments, two very important things. So we know that some of our patients have cognitive impairments and they are dependent on their caregivers for many things. So how does one deal with cognitive impaired PD patients in the COVID social distancing idea? do we prescribe masks for everybody who is cognitively impaired? Say, yep, just put on masks so that you don't have to remember to, do this when you cough, or you avoid going into a situation where you potentially infect somebody. Or do we say, well, that's part of life. You just have to, learn to do it right. What are your thoughts? Do we say that people who are cognitively impaired should potentially wear at least a surgical mask at all times, except when they go and sleeping in their own rooms? Or should you think, no, that's not needed? What are your thoughts?
So my patients are not wearing masks. When I do the home visit, virtual visit, they're both, I can see the husband and wife, I can see the pair, whoever the couple is, unmasked. They're in such a close situation. If one gets it, the other's going to get it anyway. And so, I think that the challenge is the burnout, right? They're together constantly, the wear and tear on the relationship. And so that's where online counseling, family support, kids calling more often, those sorts of things. But no, I don't have anyone wear masks. You're supposed to wear masks going outside here, but most people do.
What do you think, Pinky?
There is some data that if you wear a mask, you touch your face more. I mean, even ourselves, we notice, if we wear a mask, you have to adjust it, you feel uncomfortable. So it does increase touching your face. So I think it's not practical to wear it at all times. If they're going outside, it's better to just go at a time when there are not many people. Because I think in the setting of dementia, likely they are going to adjust the mask, maybe remove it or touch the face more. So probably just go at times when there are not enough people so that you can stay the 6 feet away. And about the, interestingly, on a personal front, my kid's piano teacher, she got COVID recently. And she has a history of breast cancer and she is on some chemotherapy, but she's doing well. And what she did was they do have a 2-level house. So not like New York, they have a 2-level house. So the moment she got diagnosed with a fever, etc., she isolated herself. So she's living in the upper floor of her house and her husband's downstairs and he's just coming in, handing meals and going back down. But he's avoided now. She's on day 7 or 8. He didn't get it and she's recovering.
Cool. Very nice. Thank you again for sharing these wonderful anecdotes from both of you all. Moving to the next area that we wanted to cover are hospital visits and missed appointments. So if one of the Parkinson patient got sick and they go to the hospital, obviously common sense would be that we avoid going to the hospitals and going to the ED, and you call your doctor and try to avoid. But if you have to go and you end up going there, are there things that you tell your patients what they should take with them, what they shouldn't take with them? Supply chain for current medications an issue? Do you say, yep, are you on Rytary? Then take your Rytary with you because your hospital may not provide it to you. Or do you say, yep, let's just deal with it as we go, and you go there and you do what is needed? What is the advice that you are telling your patients if they are on unique medicines, Nuplazid, Rytary, whatever, that's not formulary in most hospitals? Do you tell them to carry that with you in this scenario where you can let family members go home and bring your medicines, or so on and so forth, given the limited restrictions? What are your thoughts on that? Have this come across and how do you deal with it?
Well, so far, nobody's gone to the hospital for anything other than COVID. And so I think that's the most important thing I can say today. Don't fall. Don't get a urinary tract infection. Make sure you're well hydrated. Keep your bowels regular. Don't get so constipated. I don't want you to go to the hospital. So I assume if you go to the hospital, you're going to have to accept whatever's on the formulary, and your doctors will do the best they can. But it is really a very intensely busy situation. You're going to get not the level of care you might have gotten before. Right? It's going to be very, very busy. So I don't think people are going to worry about these extra drugs or bringing drugs from home. I think you'll just have to
deal with it as as it comes. Yeah.
And it's not the worst thing. If you happen to be delirious, that you take a little less medication wouldn't be the worst thing. But I'd like to hope that people don't get hospitalized at this time.
Right. Any other thoughts, Pinky? You pretty much endorse that same view, or?
Yeah, so, we've been doing the same, like Dr. Waters said, try to stay out of the hospital. But then one of my patients had to go for a CT scan today because she has DBS and she did fall some days ago. And then the initial CT showed a subdural hematoma, like a little bleed in the head. And now she's calling that she's worse. She's getting more confused. She's having more bladder problems. So there's a concern whether the subdural could have expanded. So what we've done is to avoid, normally we would maybe have just sent her to the ER, but instead of that, we put a call out to the radiology folks, set up sort of an appointment for her. So she can just go have the CT and come out. So just trying to minimize amount of time she has to spend there in the hospital setting. But we did tell her that when you go there, take your med list along, take your meds along with you, just in case they find it's a big bleed and she ends up getting hospitalized.
Gotcha. Great. So again, just to make sure our audience didn't miss some of the important points, a subdural hematoma is a bleeding that occurs inside the skull. And typically this happens after a fall in elderly people with Parkinson's disease and Alzheimer's disease and such illnesses. Even a trivial fall can sometimes cause such bleeds. And in the setting of DBS, deep brain stimulation implants, there's a higher risk for it because there's an instrumentation that's gone in, and then you can produce subdural bleeds again. Which again is a great topic because DBS is a concern to many of my patients, and I'm sure your patients as well. So what would happen if during this time when elective surgery is first of all stopped, that your DBS stops functioning? You need a battery replacement, and your battery goes go kaput, or you get the signal saying that your battery is running low when you check it. What is the advice? So my advice has been that don't worry about it. We'll take care of you medically if that's what we need to do, and we will, use a few weeks to somehow get you under managed. Especially since you're not so active, you're at home. We should be able to medically manage you during that time period. And when everything opens up again, we can do DBS again. This has been my stock answer. But again, I like to hear what you folks have been saying to your patients with DBS, and have you had any experience with it?
So clearly in New York, where we have so many cases of COVID and our hospitals are so busy, we don't want patients to come in to replace their batteries. Right. So we're not going to have them do that. We're going to do exactly what you said. Just adjust the medicines and make the best of it. Right.
Pinky, you agree with that?
Yes. There's just so much. There's just so many people out there in the ER right now. I mean, pretty much ERs are COVID ERs just now. And though our hospital has negative flow air, which means that if there's a patient in the ER with COVID, then the air gets sucked into the room rather than pushed out of the room. But even then, there's just too much out there. Recently, I heard about a little 2-year-old girl who fell at her home on the stairs. And then she had to go to Children's Hospital, and then she ended up with COVID. And she is doing well, but she did develop a cough and a fever and all that. So she went in without COVID, and she's got COVID there. So if we can stay out of the hospital during this situation, I think it's best to optimize med management rather than go in for battery replacement.
I'm going to ask a series of short questions because I don't want to monopolize the talk between all three of us, and I want to open up some time for other people to ask questions. So I'm going to ask Cheryl this question, and then, of course, Pinky, if you want to add on something, feel free to add, and then I'll come back to you. But the first question to Cheryl is, what about hydroxychloroquine and other investigational immunosuppressive drugs? Has any of your patients that you know of with Parkinson's disease or other movement disorders, dystonia, tremor, ET, whatever, that you know of that has been tried on hydroxychloroquine because they are either cohabitating with somebody who had the infection, or they're at risk, or they're a healthcare worker and they needed to be on it? And if so, any experience, any thoughts? They are on drugs that increase QT interval. For example, quetiapine is a well-known QT interval increaser. Any issues of either using the drug or not using the drug, or any thoughts about that?
So no, I mean, I was wondering, doesn't Z-Pak also have QT interval issues, the Z-Pak?
Yeah, it does.
So I had my patient was put on the zithromycin, so I had a momentary pause when I heard that, thinking, they're also on quetiapine. But I'm not seeing anyone get it for those reasons. People are getting those drugs when they're in the ICU situation in a very, very sick and very ill state. And those are not patients I'm managing. I am not in the hospital on active duty. I'm working remotely from home.
Right.
So
right.
I know patients are only getting those drugs when they're very ill.
Gotcha. Anything you want to chime in, Pinky, or?
In the Seattle area, and maybe in other parts of the country, there's a clinical trial going on for, prophylactically giving it to people who are on the front lines, like ER physicians, or, people who are checking in these, so who have high exposure risk.
Yes.
But as a routine, probably, I don't think our patients need to proactively go and start that. Social distancing is probably going to be more productive.
Right. Perfect. The next question I want to ask Pinky, and again, Cheryl, feel to chime in if this is something that you can give us some insight based on your thing. So death and DNR. So you already gave an example of COVID-related death happening and this patient having DNR. So given the current scenario that death happens in very tragic circumstances when you get COVID, you're isolated from your family, you're not able to say goodbye to your loved ones, even in the last minutes. If you have the unfortunate situation of getting COVID and you have to be in the ventilator, and even your last rites and your post-passing rituals are limited, and funeral homes are overwhelmed, and so on and so forth. So given this scenario, given where we are right now, should we be recommending to our patients to start thinking about DNR and trying to put together DNR documents if they haven't done it? Is this the right time to do it if they're healthy and they don't have any issues? Or are we just making them more fearful about doing DNR documents under the current circumstances? Is this the right thing? I've had a couple of people call me and said, well, I haven't done a DNR. Should I do it? I'm not, And what's your thoughts on it? What's your advice?
You're right. I'm sorry. Go ahead, Pinky.
I was just going to say that it's probably always the right time to think of those documents, like DNR documents, because just now we have a known risk. We always have unknown risks out there. And so it's always good to have that discussion. And it doesn't necessarily mean one has to be DNR, but as long as one's had that discussion so that the family is aware, because it puts the family in a very difficult position to have to make that decision for a patient. Mm-hmm. So as long as they've had the discussion, whatever conclusion they've come to is a fair one, as long as the family is aware of it.
Perfect. Thank you. Cheryl?
I agree. I think these discussions are hard to have, as same with the discussion about hospice. Those are hard to have as well. But I think that those are discussions we are obligated to have with our patients and their families.
So, and along those same lines too, because voice is so much badly affected, and of course, if you have respiratory system affected and you're intubated, you can't speak anyway, your gestures are going to be slow and you're Parkinsonian anyway. Should people be thinking about writing their memoirs, thinking about what they want to say, their last thoughts, etc., at this time, in the eventuality that would have happened and they have done all the things that they wanted to do? Or is it premature? Is it something that, hey, crisis, a medical crisis, a huge crisis, so we're doing things that are, not very logical. We shouldn't be doing these kinds of things. It's going to pass, and, there's going to be few people who are going to get really deadly sick, but we don't need to go overboard and do all those things. Because I've had lots of people call me and say, I haven't made my will. Should I be calling the lawyer right now? Is this the best time to do these things, or should we be waiting until better times?
You have the time to do it. If you can get your lawyer on the phone.
Okay, well, that's a fair answer. But again, I don't know whether the social anxiety that's going on with all this thing going on, is this the right time to do some of these things, whether you would be in the right mindset to do these things or not. I guess that's the $1 million question.
Well, at least you should let somebody know your wishes. I mean, that may not be legal though. That's the thing.
Right. I think I covered a bunch of these things. And the one thing that I would say, I would encourage people to do, and then again, you guys can chime in on this, for people who are dependent on care, like if you have somebody coming and checking on you every so often, or you have, younger child or daughter or son or somebody checking on you, or daughter-in-law is checking on you, you can make social groups which are, doing the same thing. So long as that group is isolated, they're living in a different household, but they are doing the same social isolation, you can partner with them. So you could have a partnering group of 10 people or so, and they can all practice the same social isolation. And that way now, when they come to your house and they're giving you care, it's no longer an issue. Because they're doing the same thing that you're doing, which is you're avoiding contact, et cetera, et cetera. So I've been encouraging a lot of my elderly folks who have had that situation where they have other people giving care for them. They have created this sort of bridges across families, usually relatives, but there's also non-relative partnerships that have happened and successfully used this to deal with the current crises. So again, any thoughts on that? Have you had any experience with anybody doing that?
In our area, and I guess in other parts of the US, there's this app called Nextdoor, where people in the community, sort of in the same zip code or same area, they all are part of this sort of chat group. So I've seen a lot of postings in these chat groups where neighbors are offering to help, especially since there are college folks at home and they're sort of at younger risk, and the high school students, they've been offering to provide care to elderly neighbors. So sort of a little community caregiving group has arisen out of this.
Okay. Any thoughts, Cheryl?
It's a complicated situation. My daughter has a babysitter who comes in, and she couldn't work if she didn't have this babysitter, but the babysitter just goes home and doesn't go anywhere else and just comes to her house. So I guess that's the group you're talking about. I had my grandchildren over on the weekend, but they didn't come into the house and they didn't come anywhere near me. They just played on the lawn. But I'll tell you, it had been so long since I'd seen them. It gave me such joy just having them even in the distance. I couldn't touch them. So.
Yeah. So any closing thoughts? I think I've exhausted my questions. I think I got most of what I wanted to ask you guys. But if I missed something in this scenario that we want to share with our Parkinson patients, I'll let the two of you go. As long as you want to go. I'm sure you have other thoughts and ideas on how our patients should deal with this situation right now.
Well, I think do your best to be grateful for every single day. Gratitude, practice gratitude. I'm grateful for people that are doing good things for others. And I'm grateful also that we are in a position as healthcare workers that we can help. So I'm grateful too.
Pinky, any advice, any thoughts on things that you have done in this last several weeks that's helped your patients that you can share with us?
So, we started, we are going to the office and doing remote visits from there. And it has been challenging, everyone doesn't have internet connection, but it would help if, since we are doing virtual visits, if family members helped somewhat on the tech aspect with, configuring their iPads or their cell phones. Sometimes our senior patients aren't sure if they have a camera or if they have a speaker. So it's been helpful when some family members been there to start the initial visit to get the tech part set up. So that's something we can do. When we call, sometimes people don't have their med list, etc., because they're used to doing things a certain way when they come to the hospital, prep for it. So if they can prep, have their pill bottles available there, have their med list accessible. Also, we've taken advantage of this, of the virtual visits to do more of a fall prevention exercise where, like I had a patient who said, he fell on the steps. So I had him show me where the steps were. And, we were able to say, okay, use a handrail, get a handrail fixed on the wall too. So, there are some advantages we can do out of the current situation too, because who knows how long these virtual visits will be allowed. But it has its benefits of seeing people in the home setting.
Absolutely. I agree with you. I think I've seen over the last 2 or 3 weeks, the few televised health visits I've done has really thrown dramatic insights on people's home situation, what they're doing when I see their dyskinesias and their walking and their gait and their balance issues when they are in their home setting. It's been very insightful, and I've gained a lot of knowledge. I think you're absolutely right. I think COVID will have its upsides, although there are a lot of downsides to it, but I think there'll be, and one of the upsides is definitely going to be telehealth. We're going to be doing a lot more telehealth, I think, and the nation as such and the healthcare system itself is going to evolve to see the benefits of telehealth, and I think that's going to happen. So I think one of the learning lessons, which I would pass on to the audience here, is that the sooner you get on the technology side of things, I just had this conversation yesterday with a gentleman who's in one of our research studies, and the research study requires now us to do either phone call or telehealth because we can't bring them anymore. So he was resisting the idea of not having a camera on the phone. And he said, well, you have a camera. So, well, I only have this jitterbug phone. I said, well, I'm looking it up in the internet and Jitterbug has a camera, so just use it. It was like, oh, I don't know if I can use it. Well, I think it's time for us to get over that reluctance for technology. I think technology is here. Technology is there to stay. It's going to get used more. So I think our audience needs to just embrace it, just like we have been embracing it. I think it's bound to happen, and if we don't do it, then I think it's just going to be a disadvantage, because sooner or later this is going to become mandatory. Everybody will need telehealth, and that's just coming, I think. So that's my personal view on it. So
sorry, just one thing. We had a couple of phone calls of some patients calling in, asking if they should take the pneumococcal vaccine or no. And I would say, if anything, this pandemic has shown us the importance of vaccines. So it's very important, if people haven't taken their flu shot, haven't taken their pneumococcal vaccine, etc., to make sure they take those. So at least you don't end up in the ER with something preventable.
Absolutely, absolutely. Great. So at this point, Samyu, can you turn on the people can ask questions if they have any questions. They can ask Cheryl or Pinky. So can you unmute everybody?
If we tell them, hey, listen, we looked at the contract, right? Regardless, if the beaches are closed, well, obviously it's extenuating circumstances. I don't think
okay,
that's
somebody. So anyway, anybody have any questions? You can either raise your hand and we can unmute you, or you can unmute yourself and ask the question. And feel free to just come in and ask questions, or you can even type your questions if you like, and you can do that too in the chat box. Some of you are unmuting everybody?
No, I'm going to let anyone unmute themselves if they have any questions.
Okay.
So that we don't have too much.
Okay. All right. That sounds good. I see Leslie Lubriani is here with her. She's one of our senior nurses. Leslie, do you wanna ask any questions based on your experience? Why don't you come on, turn on your microphone and ask your question? Yeah.
Hello, Mark.
Leslie, are you coming on? Did you have a question, Sandy? Is that why your phone is unmuted?
Well, I think Sandy doesn't have a question, she said, but we wanted to thank you all for the very informative time we've had together. Okay. We really appreciate your attention and your practical inputs that we're all very open for. So we want to thank you. I don't have a question. Sandy, I don't think you have a question.
No, not appropriately.
That's great. Thank you.
We'll say thank you.
All right, that's most welcome. Yes, thank you very much. Now, if you could mute your phone so that we could get somebody else to ask their question. Yeah, okay. Let's see. Leslie, you want to come on? And Leslie again is one of our nurses who is, and I saw her briefly. I don't know if she disappeared or not. But looks like she got shy and she's not asking questions. So
Yes,
Anyway,
she's talking.
anybody else have any questions that, I see a bunch of other people as well. I see, yeah, there's Leslie again, so. Anyway, all right, well, if there are no more questions, you know, we always are open to questions, and you can send your questions and we'll do another one next week. And if you have any practical questions, anything that came up from today's discussion, we'll have another session, and hopefully we can answer more of your questions at that time. I tried to include as many questions as I got, and as some you got. Some of you have any questions that you want to run by that has come through that I didn't get a chance to ask?
No, not really. I think you guys covered a lot very well. And I want to thank you both, Dr. Agarwal and Dr. Waters, for coming in here and giving us some very valuable information. And hearing it directly from professionals and experts in the field is I think it's very comforting and just gives us more confidence.
Okay, perfect. Okay, great. Well, thank you very much again. I want to thank both Cheryl as well as Pinky for taking the time and sharing these things.
We got a message from Leslie. She said she can't unmute.
I know, I saw that here. So, but that's okay. If you have a question, you can type it in, Leslie, if you have a question. But anyway, we can include it for the next round, I guess. So, good talking to you all, and thank you again for spending a few minutes with us. Okay, take care. Bye-bye. Bye.